This will be a very different talk than yesterday, where we got into a lot of, very complex ethical decision making and challenges to shared decision making. And this is somewhat of a much more objective talk. And this morning we've been treated throughout the day to several different discussions. And what I'll try to do is round out some of the symptom management topics in our final, using some case vignettes. So I have no relevant disclosures. And I used this slide again, and I had mentioned it yesterday, to just remind us all that when we're thinking about palliative and supportive care, it's not so much about did we get a consult or not, because as we look at a collaborative model of palliative care, whether we're looking at advanced heart disease, whether we're looking at malignancy, we're really looking at focusing on how do we treat the disease with curative or disease-targeted therapy, but we also recognize very clearly that we all have a role for managing symptoms and quality of life. And all of us, whether we're specialists or whether we're primary care providers, or whether we're specialists who are asked to do some primary palliative care, we all have a role in managing symptoms for our patients. And really, as we move through time, there may be a much greater focus on what we can do from a palliative perspective, because we may have less tumor-directed or disease-directed therapies. But what I really want to focus on is how do we fill that yellow box up so that we all feel more comfortable with some of the symptoms. How do we think about palliative care? Again, you've heard some great examples of comprehensive palliative care that's not hospice, that's not end-of-life care, but really focused on symptom management. And you've heard some great examples of how some very problematic symptoms are discussed, from pain, and some great talks on fatigue and cachexia, anorexia. You heard about mood, and you heard about lymphedema and secretion management. So really what I'm going to try to do is round that out with some case examples today, and certainly we can't touch upon everything, but I think hopefully we'll feel satisfied leaving here. So our first case is a 58-year-old female, triple-negative breast cancer, lymphangitic disease. She complains of dyspnea on exertion even with minimal activity. She's stable on 4 liters of supplemental oxygen in terms of her saturation. She does not appear anxious, but she's very frustrated that she's limited by her dyspnea. And you take an exam, her physical exam shows coarse breath sounds bilaterally. There's no dullness at the bases. And you check some vitals, and pulse is 86, respiratory rate 16, 94%. And you just have her get up off and move from the bed to the chair and see how she does with that. You see pulse goes up, respiratory rate goes up, sats stay at about 91%. So in this particular situation, okay, you may be thinking we're going to do steroids that would help with this, and we may think about tumor-directed therapy, of course, but which is the next appropriate step of management? Now, this isn't the type of thing where we have a little go ahead and vote, and this isn't the type of thing where I make anybody raise their hands or shout out answers. But since we're all competitive, it's very fun to go ahead and give the answer and hear everybody go, yes! Because just like when you're in med school, you want to get that yes. So what do we do for this particular patient with dyspnea? Do we give haloperidol? Do we try some sub-Q or IV morphine in the inpatient setting? Do we try nebulized morphine? Do we try some lorazepam, because we know that can help? Or do we try to get her something better? She's only on 4 liters of oxygen. So think about that. And for me, what I would argue or want us to try to take home is that I would argue for this particular patient that number 2 is the correct answer, that we would think about low-dose morphine in this particular situation. And we'll talk about why. So when we think about dyspnea, it's really important to think about what's causing the dyspnea. There are a lot of different etiologies that can be causing, whether it's an AA gradient or some kind of VQ mismatch or some kind of fixed obstruction. And there's a lot of different mnemonics and anatomic rationale for thinking about this. I added this breathe air mnemonic, but if you ask me to say breathe air, I'm not a mnemonic thinker, so I would be B is, I think, bronchospasm, yes. So I don't think about what the letters are very well, but I do think for me anatomically about, okay, starting up in our heads, what's going on in terms of anxiety or existential concerns, interpersonal concerns. What about upper airway issues with either secretions or anatomic considerations? What about small airways, wheezing, medium-sized airways, bronchiectasis, Around the lungs, what are we thinking about in terms of effusions, or what are we thinking about with interstitial disease, where we might have some alveolar limitations because of scarring. So, and then also there's, is the person just markedly anemic? Is there clots? Are there reasons that we're not getting oxygen that is being breathed in, transferred over to the blood and supplied through? So when we think about dyspnea, I think the most important thing that I want to emphasize before talking about very specific examples of what to treat is that it's really important, and sometimes families don't get this, and often patients won't get this, but there's a very big difference between hypoxia, between dyspnea, and tachypnea. There are three different things. So I'll often have patients come in and say, I don't qualify for home oxygen, so I don't use it because my numbers aren't low enough. Okay? And you check their SATs, and they're 91% like our patient was right here. Yet they're breathing 24 times a minute, and they're tachycardic, and they're clearly having trouble breathing. There's increased work of breathing. Then I also take care of patients that have pulmonary hypertension quite often, and they'll come in and be kind of a little bit on a bluish tinge, and you check their pulse ox, and it's 81% on 5 liters via nasal cannula, and they say, I'm doing fine. It's just how it is. And the nurse at the station was like, doctor, come in, it's 81%. Like, what are we gonna do? And that's just where they live. They have cor pulmonale, they have pulmonary hypertension, and they're not short of breath. They're hypoxic, but they're not having dyspnea, and they may not be having tachypnea in that particular situation. So it's really important to say, when that patient says, I am short of breath, it really doesn't matter to me. The SATs help me to say, do I need to supplement with oxygen? But really I need to treat that sensation of shortness of breath. And what we know is that opioids have the best evidence for that. And there's a lot of different studies that I could quote, most of them through David Crow and Amy Abernathy collectively in Australia and throughout the United States. And again, it's really showing that single-dose long-acting opioids or use of short-acting opioids in an appropriate fashion do not cause people to become hypercapnic, tend not to cause people to become overly somnolent, and certainly can help with dyspnea and cough. So I think the important thing is, sometimes folks will say, oh, I'm going to use a weaker opioid like codeine cough syrup, and I don't particularly like codeine. I know you might have heard about that earlier today. Again, there's some pharmacogenomic variation. Some people might even use hydrocodone for cough and dyspnea as well. But if we know that we're going to use a strong opioid, we tend to know what people are getting. We can use the lowest effective dose, and we could titrate it to benefit. And it's amazing how people will use a little bit of oxycodone or hydromorphone and say, gosh, that really, really helped me to feel like I'm breathing. It's also amazing how many people we give that to, and they say, I said, did you try that? And they said, well, I don't have any pain, doc, so I didn't take those pain pills you give me. I don't need any pain pills. So it's really important as clinicians that we say, these aren't your pain pills, even though you've used oxycodone for your hip replacement before. I'm giving this to you for shortness of breath. So even with some good upfront education, sometimes we as clinicians need to do a little bit extra education in that regard. Now, benzodiazepines can be effective if it seems like anxiety is driving the dyspnea, and sometimes that's the big question. Is the person dyspneic so they're becoming more anxious, or are they anxious which is making them more dyspneic? And sometimes it really is a chicken and egg phenomenon. What we know from the literature is that use of benzodiazepines, particularly with use of opioids in patients with conditions like COPD, can be associated with a slightly increased risk of mortality, and that was some work published in Europe over in BMJ. But I think overall, again, if we have someone who's somewhat naive to both of these medications and say, gosh, this person is dyspneic and we think it's pure dyspnea from a pulmonary cause, if I had to pick between 0.5 of lorazepam or 2 milligrams of, or 2.5 of, or 5 of oral morphine, I'm probably going to pick the morphine as long as they were tolerating, because we know that the opioid tends to be more effective in terms of relief of dyspnea. Now, corticosteroids, again, it comes down to how you're going to use these. You've heard about how corticosteroids can decrease inflammation, and certainly for some can improve a sense of well-being over the short term. How you're going to give these in terms of, I believe, Dr. Barrera mentioned earlier this morning, and Dr. Barton afterwards, 8 milligrams a day. I tend to do it 4 or twice a day because if they get a little boost when they wake up in the morning, and then I give them another boost sometime between 12 and 2 in the afternoon. Hopefully they get a second little boost there. And again, there's always going to be the risk of fluid retention, so if folks are having dyspnea because of heart disease, we have to be careful with that. But it's amazing how many people will benefit from this, and I took care of a dentist with IPF for a long time who had tremendous benefit from dexamethasone. His cardiologist was really nervous because his lipids weren't ideal, but the dentist was very clear to me. When he came in about 3 months later, his face was a little puffy and he had a little bit of a hump, and I said, gosh, I've never really done this to somebody. And he looked at me and he said, don't you touch those steroids. And it's like, but you know, you're kind of a little puffy. He's like, I could still garden. Like, I'm okay with how I look. Like, I can get up. It's still helping me. So I was a little worried. I was like, but that cardiologist is going to be really unhappy if I make your lipids suboptimal. Because this wasn't a person who was, you know, very much at the end of life. But he did very well for 6+ months on steroids. And, you know, we really have to weigh the benefits and burdens in that particular situation. And that patient's goals absolutely were met by the steroids. If there are specific therapies that we could use that treat the underlying cause, we want to do that. And I mention this because, again, we talked a little bit about comfort care and how sometimes when patients are moved to comfort care, there's this overwhelming majority to just truncate all medications. And if we have patients who have advanced cardiac disease or who have renal disease but are still making urine, we need to use diuretics. And stopping diuretics is going to be something that's going to make them feel worse. Stopping inhaled therapy, and I put albuterol up there, but again, thinking about anticholinergics, if someone is on tiotropium and tiotropium's helping them, and we say, gosh, they want to potentially go on hospice and we want to try to save some money, you know, we have to think about these drugs may be helpful, and maybe we switch to more frequent dosing of ipratropium, but we don't just want to stop it, because if it's helping the person, we definitely don't want to stop these treatments. And then certainly we talk about procedures. We could think about bronchoscopy for obstruction, but we also can think about treatments like thoracentesis and now percutaneously placed pleural drainage systems, which can be very effective. And it's not only pleural-based percutaneously placed pleural drainage systems, but also for people that have tremendous amount of ascites that is causing issues with diaphragmatic excursion. They can't take a deep breath. They continue to require frequent paracentesis. Is this a case where they might benefit from having a percutaneously placed intra-abdominal drainage catheter? And again, there's different milieus when people have malignant carcinomatosis and malignant ascites versus non-malignant ascites. But yes, I have put pleural-based, or excuse me, abdominal-based catheters in patients with liver disease and heart failure as well, recognizing that maybe there's a slightly increased risk of infection in those patients over those that have malignancy. But for them, the goals of care were met by that treatment. They were able to stay at home. They were able to comfortably have their symptoms managed. And I wasn't going to sit there and worry about, am I going to cause peritonitis for this particular patient? And still, we always worry about that risk of peritonitis, but it just really hasn't borne out in any of the small studies that have been done with these implanted drainage systems, that the rates of infections really don't appear to be as high as one would think. And some would ask about novel therapies such as nebulized opioids. I think it's really important to recognize that opioids systemically given, either enterally or parenterally, are the gold standard. And really there haven't been any great studies that have really shown that there's definitive benefit to use of inhaled opioids. Now, when I was a fellow at VCU, they couldn't do a study on nebulized fentanyl because it was so ubiquitously used throughout the hospital that you couldn't find people who were naive to this. So we used a lot of nebulized fentanyl in that particular situation. There are other institutions that it's kind of a naughty thing and it doesn't even get mentioned. I think the biggest thing that I want to make sure that folks recognize is that if someone derives benefit, and we do have, again, small evidence, case control, or small cohort series that say this might help. If someone says, when I take that fentanyl neb, it helps, and it seems to not be causing them toxicity, I think that's very reasonable to use. If the person says, it's not helping me, these therapies can be expensive, they can be cumbersome, and it's really not something to continue. And the worst thing I want to see is someone who's not getting benefit from this therapy to be continuously offered it when it's just not helping them. Or the person to say, well, I'm not going to give them their 5 milligrams of morphine concentrate sublingually because I just gave them a morphine neb. Shouldn't they be feeling better? Morphine is a very hydrophilic and macromolecular structure that doesn't tend to be absorbed very well. We know there's opioid receptors in the lung, but if they're not getting benefit from it, we have to recognize that systemic therapy is where the evidence shows we should be. In terms of anxiety, again, we have to really think about anxiety, and you heard some great pearls about management of depression, and sometimes depression and adjustment and overlap, depressed mood and anxious mood, it's sometimes very tricky. But really exploring, when you see that patients have concerns, are there particularly identifiable remedies? And if someone has really significant concerns about leaving their children, or feeling like they have unfinished work that hasn't been done, or worried about the legacy that they're going to leave behind, I find that those existential and bigger interpersonal issues tend not to do well with things like clonazepam or SSRIs or anything, except really getting to the root of what's causing the problem. So we have to recognize that, particularly with our hospice teams and particularly in our oncology settings where we have multidisciplinary care, that our social work, our nurse, our psychologists, our counselors, our chaplains play a huge role in sometimes helping to mitigate anxiety for patients. When we think about anxiety, I think it's also important, we talked a little about pain, about dyspnea, and the chicken and the egg, and it's really important to make sure that these treatments are managed, that these symptoms are managed. So is the person really acting anxious because their pain isn't controlled or because their dyspnea isn't controlled? And generally, if benzodiazepines are going to be used, and in my palliative care setting where people have a little bit more of a limited life expectancy, they tend to be more of something that I would use. I tend to avoid the very short-acting opioids like alprazolam, because these are the folks that come in with untreated anxiety who get the medication, they take their alprazolam, they feel good, it's gone in 2 hours and they feel lousy again and they need something, and then they take their alprazolam again, and then they just yo-yo up and down all day long. So really thinking about some of the therapies that you heard about earlier, can we use SSRIs? Does the person have a survival that would suggest this? If they don't have a survival that we think is that long, at least using something moderately acting like lorazepam, or if we're going to use something long-acting, I tend to use clonazepam, and that's really because things like diazepam just have some metabolites that can hang around. And clonazepam, we have to be careful in the elderly and if they have liver disease, but clonazepam generally can be done fairly safely. We just have to be careful in watching for side effects and prolonged efficacy. The non-pharmacologic methods that you heard about from Dr. Barton and Dr. Butler applying to other aspects certainly can apply to anxiety as well. And I think it really comes down to, again, what's driving the anxiety? What are the person's goals? What are they willing to work on? And are they open to any of these mindfulness or mindfulness-based therapies that potentially could be helpful? If the person's really, really ill and has a limited life expectancy and isn't able to participate in those therapies as they're further along in life, sometimes that's a challenge. So when we talk about the evidence-based practice, again, I mentioned earlier the opioid situation, excuse me, where most of the work, Amy Abernathy, David Carreau, have looked at long-acting opioids, once a day, 20 milligrams of morphine extended release, not available in that dose in the US, but done in Australia, very effective for patients with very minimal side effects. The opioids plus benzodiazepines, again, BMJ, it's Ekstrom et al. You can look at a nice paper that looked at benzodiazepines that, again, could potentially, when used in combination, increase mortality risks. And supplemental oxygen, we get back to that patient of differentiating between hypoxia and dyspnea. And Amy Abernathy, again, in a large study looking at supplemental oxygen delivered via nasal cannula versus medical room air delivered by nasal cannula really demonstrated that in patients who are normoxic, there does not appear to be any evidence of benefit to dyspnea for patients who receive oxygen. So we recognize that oxygen is a very potent symbol of medical care. You know, you think back to the nursing days, someone comes in, they're in distress, and I come in and the first thing the nurse would do is put oxygen on the patient in the hospital. And that's okay in the hospital where we have pretty much an endless supply of medical oxygen in a little green spigot in every room. But when we're thinking about rural areas of Alabama where, unless we have a person who's qualified for this therapy because Medicare needs an 88% or less to pay for it, or unless we, if we are on hospice and we're thinking about a comfort-directed strategy, there's still cost and setup and risk associated with having oxygen in the home, particularly if we have folks that are smoking or have possible sources of ignition. So to just use supplemental oxygen indiscriminately doesn't appear to be beneficial. And the reason that we think the room air may be helpful is because, you can think about you're hot and we all kind of start going like this. And that's a very common thing because we're trying to stimulate air movement and stimulate our trigeminal afferents that are telling us, wow, I'm getting enough air at this time, and that sends a signal back to my brain to say, oh, it's okay that it's hot in here. I'm getting enough air. I could calm myself down. So using things like using things like fans for patients in our inpatient palliative care unit is very common versus just necessarily using supplemental oxygen because, again, in the normoxic patient, it may be something that isn't necessarily helpful. And that's where opioids differ because, again, opioids are treating dyspnea, and it really doesn't matter. Opioids don't discriminate between hypoxic and normoxic patients. They help everybody with dyspnea for the most part. So we're far enough away from lunch to talk a little bit about constipation, and Dr. Barrera put up a great picture of a belly full of poop this morning. So I think it's really important for us to all remember the proverb of if you write the opioid, you better write for the laxative, or you're going to be the one disimpacting the patient or taking the call when they come in to the emergency room. So some of the pearls that I like to put out here, first of all, this is a ubiquitously huge problem. So, I think it's something that you don't just have to think about the cancer patient population, it's really opioids nonetheless. So about 3 weeks ago now, I had a cervical fusion done. And I was just in overnight, and they were bringing me my hydrocodone, and I was like, this drain hurts, I can't wait to get it out. And basically, the nurse said, can I get you anything? And I said, has someone written for my Senna? And she said, no. And I was like, well, you don't have to wake up the resident, but next time the resident calls, they better put in for my Senna because I don't want to wait till we have a problem. And that's really how we should think about this. Evidence of saying, oh, I'm on a stool softener using Docusate alone, it's not really a good habit to get into. And the way I say this is because opioids decrease gastrointestinal motility. So if we're not having a prokinetic effect where stool is moving through because opioids, that means that stool has a longer contact time with gastrointestinal mucosa, which means more water is going to get absorbed, which means we have hard poop that's not moving forward. So giving a little bit of a softener just makes soft poop that's not moving forward. So people say, I'm taking my stool softener, yet they're distended and have that x-ray that we saw earlier. We really need to do something that is either going to be a stimulant where it's going to move it forward. So we think of those as our Senna or Bisacodal, or we have to think of something that's so kind of osmotically loaded that the amount of water that is retained in the lumen is sufficient that it's going to push the stool forward. And that's where we think of things like magnesium hydroxide or milk of magnesia. We think about polyethylene glycol, which again is great for a lot of folks, but 8 ounces of fluid when someone has a little bit of early satiety or doesn't really want to drink, we have to be careful. I don't want them taking 8 ounces of their capful of polyethylene glycol in the morning and then they don't want to eat anything else because there's not calories in that. So We want to have an intensification plan, so thinking about something rectally, whether it's a suppository or an enema, really tell patients don't go at 2 days. If you haven't had a bowel movement in 2 days, we really need to start thinking about what are we stepping up to. And in terms of throwing in a little bit of extra literature, there was a nice little study that was done, published about 3 years ago now, because again, we have a lot of people on Senna, but some people will get Senna S, and is there really benefit of saying that a person who gets 2 tablets of 8.6 milligrams of Senna is any different than a person who gets 2 tablets of 8.6 milligrams of Senna and 50 milligrams of docusate sodium? And it really showed that there's just not benefit, particularly in the hospice patient, because again, these folks are getting opioids for the most part, and there's just really not enough of the softener in there to change anything. One of the real challenges, and as point number 3 is, again, folks might say, well, I'm increasing my fiber intake. Or I want to use psyllium-based products, or I want to use calcium polycarbonyl tablets. And you have to think that those work on normal gastrointestinal issues. So my wife takes an iron tablet in the morning, gets a little constipated from it. She could take 2 calcium polycarbonyl tablets with some water, and basically what's going to happen is the fiber is going to hold water in. When you hold water in, the gastrointestinal lumen stretches. When you have stretch of the gastrointestinal serosa, that triggers the myenteric plexus to say, let's push this out. And voila, in a normal working gastrointestinal tract, that works great. But we talked about opioids causing that myenteric plexus and promotility to not be as effective. So we can't just give people who are on opioids extra psyllium or calcium polycarbonyl or other bulking agents, because really all we're doing is adding straw to the clay that's going to make the bricks that don't go anywhere. So really it's kind of like the big bad wolf definitely will not be blowing anything out, because we don't just have clay bricks in there, we've added straw to them and made them particularly stronger. So that's where we see people, again, those bulk agents, the myenteric plexus has to work, but they also have to drink enough water. So if the person isn't going to drink 8 to 12 ounces of water after that, well, that's going to be a problem, because you're just giving them kind of like the seeds of straw to be planted in there unwatered, and they run into problems and come in with impaction and other unfun things. Now, a lot of people ask about methyl naltrexone and other opioid antagonists. When I was a fellow, it used to be giving people naloxone orally, and you'd have to open up about 10 little vials of the 0.4 to even get them 4 milligrams, but they had to take between 4 and 20. And so the pharmacy's bringing up a whole tray of naloxone, and you worry, are they going to have some withdrawal from this? So we knew that wasn't the ideal situation. So methyl naltrexone came out in about 2007, 2008, at least to market. And this is a quaternary amine, so it doesn't cross the blood-brain barrier. So in theory, it should stay within the area of the gastrointestinal region. It should cause reversal of opioid effect on the gut, but shouldn't cause withdrawal. And all of that is in theory, and it should, but there certainly are cases where there's reports of some withdrawal symptoms. It's small. It's definitely less than 1 in 4. It's probably between 10 and 20% in some of the studies. But we just have to remember that you shouldn't withdraw, but sometimes patients do report those symptoms. The drug can have excellent results, but it can be expensive. So there was Mary McPherson from University of Maryland presented a topic on this, and her quote that was tweeted at our meeting last week was, if you're thinking about the costs associated with getting methyl naltrexone to have a bowel movement, it could be up to $500. That better be one magical bowel movement experience. That being said, I haven't found that it's been that expensive. Usually, folks, it can be $40 or $50 a dose, and usually it works within 4 hours if the first dose works. If not, by the second dose that they get 48 hours later. And really the issue becomes, is it less expensive to give someone a dose of methyl naltrexone now and a dose to take home than it is to have them come into the emergency room and be seen and be evaluated and get an x-ray and get a disimpaction and the E&M charge and the CPT code associated with all that. So, there are persons who you could think, gosh, this is helpful. But we have to think if there are issues related to possibility of obstruction, we really don't want to be doing this, because there certainly, even in the absence of obstruction, have been a small percentage of gastrointestinal perforation associated with this particular treatment. And again, I had a lady who had really bad COPD, could have been in Dr. Barrera's talk. She weighs about 87 pounds from her COPD and cachectic, and she had a non-malignant bowel obstruction, but was taking some low-dose opioids and said, oh, I want that methyl-naltrexone. And I was like, not the lady that you want to have even a small perforation, just not going to do well with that. So there was a recent meta-analysis published within the past month or two that continued to confirm, looking at all the studies for methyl-naltrexone that are available, that this can be something that's beneficial for opioid-induced constipation, but it stops there. So when I have folks that come in and received one dose of 5 milligrams of oxycodone post-operative for a hip, yet they have long-standing chronic constipation and are dehydrated and haven't eaten and haven't had a bowel movement for a week, well before the time they got their 5 milligrams of oxycodone once, that's not probably opioid-associated constipation. And this particular drug is not indicated for non-opioid-associated constipation. Drugs like Lincotide, and the other one is lubiprostone, certainly are indicated for the chronic constipation, predominant irritable bowel. They tend to act on the chloride channel to, again, make that chloride channel not be able to cause chloride efflux and cause more water to be kept in the lumen. So in that particular situation, they can be helpful for the chronic constipation. And then naloxegol is an oral agent that is an opioid antagonist. This has just come out within the past year or so. There are studies, and I have patients that ask me about it. And what we have to remember is this is not FDA approved for this is only FDA approved for non-cancer and chronic pain. This is not approved for the person who comes in with pancreatic cancer on opioids who has constipation. It is only approved for patients who have chronic non-malignant pain. Okay. So what about bowel obstruction? So I mentioned a little bit, we have to make sure that we rule out the actual constipation being the issue. And when we think about malignant bowel obstruction, there's lots of different malignancies that could be associated with this, from our gynecologic to our gastrointestinal, or something that's metastatic and cause carcinomatosis. When we think about initial therapy, it tends to be, conservative management, making sure fluids are given and electrolytes are balanced, and nasogastric tube is placed. Again, trying to decompress the bowel, see if that bowel can unkink itself, if there is a little kink in there. We want to make sure that they're getting appropriate analgesia for this, because we know colicky, crampy pain is with it. But when we think about medical management, there have been a lot of different things looked at, and it seems as though dexamethasone definitely is indicated for this group. And Corot had that paper that I included there is just a nice study, and then the Berger is just a nice review that looks at this. There was a nice study in France that looked at dexamethasone as well. Just kind of synthesizes the evidence that's out there. But again, these are folks that might get 4 milligrams or 8 milligrams of dexamethasone 2 or 3 times a day. If there's edema associated, I always say if there's bowel and there's 2 adhesions or 2 pieces of tumor that are really pulling on that bowel and kinking it, giving that steroid is going to help to get rid of some of that gut edema and maybe allow things to start moving through on their own. The anti-secretory agents like octreotide certainly have been shown to be beneficial, particularly in the higher grade bowel obstructions. They're costly in the outpatient setting, but certainly can be beneficial. They decrease enteric secretions by being analogs of somatostatin. So all of that enteric secretions from our pancreas and our gallbladder and within our gastrointestinal lumen goes down, so we're not making as much. You could block as much enteric or enterohepatic secretions that you want, but if the person is drinking 2 to 3 quarts or taking in 3 or 4 meals a day, the octreotide really can't dissolve that and make it go away. So this is really for people who are NPO, or in very specific situations where we have folks that are at the end of life and we're trying to get them home in a given situation. But to give this particular medication to them, and if they continue to eat, there's still going to be extra residual fluids and extra residual contents. Proton pump inhibitors, certainly decreasing acid. Some older studies have looked at anticholinergics. So again, do we use things like scopolamine or hyoscyamin to try to help with some crampy abdominal pain? Sometimes that seems to be helpful for some patients, sometimes less so. And then antiemetics, we'll talk about that specifically on metoclopramide, which we heard a little bit about earlier this morning. And metoclopramide does have that prokinetic effect. We just have to remember that if someone has a complete bowel obstruction, we don't want to force our gastrointestinal myenteric plexus to be forcing contraction against a closed obstruction. So we're really looking at this an incomplete bowel obstruction and in tandem with use of dexamethasone plus or minus octreotide. Okay. So in our final 10 minutes, I want to talk a little bit about nausea and vomiting. And I think for me, the way that I try to wrap my head around this is, just like if we're thinking about antibiotics, and we think about, gosh, this person has a urinary tract infection. What do I think is causing a urinary tract infection in a 65-year-old woman? Probably a gram-negative. So ciprofloxacin is probably the drug that I would use. Very logical approach. And I think it's very important to think about nausea and vomiting that way, or else you're going to get stuck in situations where you keep giving people things like vancomycin for what's likely E. coli, and it's not going to work. And this is where we see a lot of people who come to palliative care clinic and they're getting a whole lot of ondansetron. And as Dr. Barrera said earlier, it's just not an ondansetron problem at this point. It's not chemotherapy associated, and it might be a motility issue. So if we think about this example of a 46-year-old patient with ovarian cancer, she comes in with 2 days of nausea. She's really not able to keep much more than medicines and sips down. She's 17 days out from her chemotherapy, and her oncologist basically treated her pretty heavy. So you all know whether you're giving her a Prepotent or palonosetron or whatever drugs you're doing up front. The nausea for her is worse with movement, worse after eating solids or liquids, and it's accompanied by abdominal distension. She uses oxy immediate release, 10 milligrams 3 times a day. Her last bowel movement was 4 days ago, and that abdominal x-ray could basically be read exactly as Dr. Barrera did, where the radiologist says there are no air fluid levels, there is no free air, there is no evidence of large bowel obstruction. Clinical correlate is indicated. And you look and say, there's also a moderate amount of stool in there, but that's the clinical correlation. So for this patient, are you thinking that if you're going to give them something orally, are you going to do metoclopramide? Are you going to do ondansetron? Are you going to do promethazine 25 milligrams every 6 hours? That could be oral or rectal. Are you going to use lorazepam 1 milligram every 6 hours? Or are you going to use a longer acting 5-HT drug like granisetron? And what I would argue is similarly to what was discussed earlier throughout the day, I'm going to argue probably for metoclopramide in this situation, because I think the situation that we don't have, it's too far out for chemotherapy-associated nausea and vomiting, so this isn't likely to be a 5-HT3 responsive problem. So it's not an ondansetron or granisetron type of problem. It doesn't seem like she's bothered with anxiety or other types of things that might be anticipating something that's causing nausea. This doesn't seem like it's a benzodiazepine kind of problem. And we'll talk about metoclopramide versus promethazine and why I would pick that in the forthcoming slides. So when we think about specific pharmacology, again, just like you pick the antibiotic gram-negative for gram-negative, gram-positive for gram-positive, you want to think about, gosh, if the person is on a cruise ship and they're getting sick to their stomach, we know that that's a vestibular issue, and that tends to be helped with anticholinergic antihistamines. So we tend to recommend those. If we think that it's a gastrointestinal distension problem, then we tend to think about peripheral serotonin antagonists and dopamine antagonists, which really, that's your metoclopramide right there. Or for some patients, when you're really gone through line 1, 2, 3, and 4, maybe something like olanzapine might be something that would be indicated in this setting because it hits more than one of these receptors. When the person tells you, I don't want to come into the chemo suite, I'm anxious about that, when we think it's cortical, or when mood seems to be impacting it, this is where dronabinol might help. This is where you might be helped with benzodiazepines or also dopamine antagonists. If it's a CTZ-mediated phenomenon where we think of toxins, where we think of chemos, where we think of endotoxemia, that's where your serotonin antagonists, your ondansetron, granisetron, et cetera, are helpful. This is where your neurokinin inhibitors like aprepitant are helpful. And if it's an intracranial pressure issue, we tend to think about corticosteroids. And just to save us the time in case there are any neuroanatomists out there, no, the picture is not anatomically correct. So I know sometimes folks look and say vestibular center at the corpus callosum, so we just try. Neuroanatomy was not my strong suit, so the arrows are there for no anatomical purpose. Now, that's just basically what I had said, and it's for your reference, but this is an anatomically correct picture from Gordon Wood and Jamie Van Roon when Gordon was a fellow at Northwestern. He's back there now on staff. But really thinking about, what receptors are responsible for what particular symptoms? So when we're thinking about chemotherapy trigger zone, we're thinking about drugs, metabolic products, or toxins. We're thinking about neurokinin, 5-HT3, and centrally acting dopamine. So that's why things like, again, haloperidol, metoclopramide, ondansetron, aprepitant, absolutely appropriate. If we're thinking about motion or labyrinth disorders, if we're thinking about a cerebellar stroke, posterior circulation stroke. So, I remember being a senior resident, patient admitted to my service, transferred from outside hospital, refractory nausea and vomiting, consideration of a PEG tube. They said, we're giving her everything we can. She's on ondansetron. We tried metoclopramide, and we think she needs a PEG tube. But it turned out, again, she had a very small pica stroke, and that really was something that an anticholinergic antihistamine would be most helpful with. So you look at all these and say, well, gosh, you had promethazine up there. Where does promethazine fit? And for me, my own individual bias is that promethazine doesn't fit anywhere in there because promethazine doesn't really do any of these things well. It probably, if we had to put it into a box, it's probably mostly anticholinergic antihistamine. So mostly helps people by falling asleep nauseous and then waking up nauseous. Promethazine was the one thing that the nurse at my college, Ma Gable, she just went by Ma, could give out basically without a doctor's order. So if you came in with postnasal drip, you got promethazine. If you came in with a hangover, you got promethazine. If you came in with a sore throat, you got promethazine until you saw the doctor who determined if you should get your throat swabbed or not. I tend really not to and use this a whole lot. And I think it's just because, again, why, if we're going back to the antibiotic example, I don't need to use chloramphenicol if I know that I have ciprofloxacin or sulfa or something else that's effective. I don't need to use this drug. So for me, it really doesn't help me. I don't know where to put it in this box. And if someone says it helps, I don't really know why it's helping, probably because it's making them sleepy. But it's not really a very powerful antiemetic. That's why I tend not to put it in my hospice order set. I'd rather use haloperidol. If I know that it's dopamine, if I think that dopamine's responsible, there's nothing really that blocks dopamine better than haloperidol. So for patients that have very strongly mediated dopamine associated nausea, I would give them 0.5 milligram of oral haloperidol 3 times a day, and their nausea will go away. It's really dramatic. And again, sometimes we worry QT intervals, et cetera. For my populations, I tend not to worry too much about that. So we want to think about our history and physical. We want to not pick 2 drugs from the same class. So we don't want to do scopolamine and diphenhydramine. We don't want to do diphenhydramine and promethazine. We don't want to do metoclopramide and haloperidol together. We want to try to think about synergy in these particular situations. Reassess if it's helping. Think about adjuvant therapies to our standard 5-HT3 and antidopaminergic. If we think that there might be a posterior component, antihistamine. If we think there's an anxiety component, benzodiazepine, or if there's a potential for chemo or a mass, we're going to think about steroids. Okay. heard a little bit about this, so I'm just going to briefly go through this case. This is a gentleman who has lung cancer and COPD. You get called to begin comfort measures on him. He's going to be extubated for comfort. He gets lorazepam and fentanyl. He gets some haloperidol. There's a scopolamine patch that's on the comfort care order set to help with death rattle. Basically, you think he might die in an hour or two, and 6 hours later you come back and he's actually very awake. He appears more alert and animated, but he's agitated and smacking his lips. He's trying to talk but can't really do so, and you just don't know what to do. So if we had to think about this, is this lorazepam, is this fentanyl, is this scopolamine, is this Haldol, or is this all of the above? Anybody want to shout out? I'm just curious. Anybody? Well, I try to throw the lip smacking in there, and I think it really gets back to some of the points where Dr. Murray was very clear about switching when you use anticholinergics or not. And in secretion management, for management of death rattle, there's not great pharmacologic evidence that shows that any of these things are better than not. But what is really important to recognize is that we tend to do anticholinergics to try to help with death rattle because we're treating the family, even though it's not the patient isn't experiencing discomfort, it's just secretions that are retained. But we have to recognize that we can do harm with these drugs. So just putting someone on an anticholinergic and a histamine because it's on our order set without them having symptoms, you can precipitate anticholinergic delirium. If the person is awake and asking for water and they're thirsty and you're giving them a drug to try to dry up their secretions, that's a very uncomfortable situation to be in. We want people not to get deeply suctioned. We don't want them laying on their back if they're really gurgling. And how many times do I walk in and the person's still getting 75 cc's an hour of fluid with their PCA, and really all that fluid is just going to make them gurgle more and more and more. And thank you so much for being here. Appreciate it.